Parkinson's disease, Lesson 3 of 6. Definition. Parkinson's disease, PD, is the second most common neurodegenerative disease. It is a progressive disease characterized by delayed initiation and execution of movement, increased muscle tone, tremors at rest, and impaired gait changes. PD is more common in individuals aged 65 and older. If someone is diagnosed with PD before the age of 50, it is considered early onset. Etiology and pathophysiology. Similar to MS, the exact cause of PD is unknown. Patients with PD develop protein aggregates inside nerve cells within the brain, known as Lewy bodies. The presence of these aggregates leads to abnormal brain functioning that can affect cognition, movements, mood, and behaviors. No apparent genetic predisposition has been identified with PD. Still, environmental factors such as exposure to well water, pesticides, herbicides, industrial chemicals, and wood pulp mills may increase the risk for PD. The hormone dopamine also plays a role in PD, where individuals with the disease have decreased levels of it. Dopamine, also known as the happy hormone, is produced by neurons in the substantia nigra of the midbrain. Individuals with PD experience degeneration of this area of the brain. This causes an imbalance between dopamine and acetylcholine in the basal ganglia. Dopamine is essential for the normal functioning of the extrapyramidal motor system, which controls posture, support, and voluntary movement. Clinical manifestations of the disease do not occur until 80% of the neurons within the substantia nigra are lost. Atypical Parkinsonism does exist and can occur after exposure to chemicals, illicit drugs, carbon monoxide, and the use of certain medications such as metoclopramide, lithium, methyldopa, and haloperidol. If this is related to medications or drug use, the individual needs to stop them so that the symptoms resolve. Image source: www.porterhousemedical.com/news/Parkinson's-disease -hopeful-future/clinical manifestations. Individuals with PD experience a gradual progression of symptoms. Use the mnemonic TRAP to remember the common clinical manifestations. T. Tremors. R. Rigidity. A. Akinesia, loss or impairment of voluntary movement. P. Postural instability. Early manifestations include mild tremors, a slight limp, or decreased arm swing. As the disease progresses, manifestations change to a shuffling gait where they appear unable to stop. Flexed arms with a loss of postural reflexes, and speech difficulties may be present. Clinical manifestations can be separated into two groups: motor and non-motor. Motor, tremor, often first sign, and initially mild. It is more apparent at rest. It can involve the thumb, forefinger, pin rolling, diaphragm, tongue, lips, and jaw. Rigidity involves increased resistance to passive motion when limbs are moved through passive motion. Sustained muscle contractions cause this manifestation, resulting in muscle soreness, fatigue, achy, slow movement, and head, upper body, spine, or leg pain. Akinesia, loss or impairment of voluntary movement. Autonomic movements such as eye blinking, swinging arms when walking, swallowing, facial expressions, and small movements to adjust posture. Bradykinesia, slowness of movement, is common in PD due to the loss of autonomic movements. Postural instability, unable to stop forward or backward movement. Non-motor, depression, anxiety, apathy, pain, urinary retention, constipation, erectile dysfunction. Memory changes, complications. As PD progresses, the risk for complication increases. Potential complications include spontaneous involuntary movements, immobility, dementia, depressions, hallucinations, psychosis, dysphagia, increased risk for infections, falls. Image source: Stanford Medicine 25.stanford.edu/the25/parkinsondisease.html. Diagnosis is based on the patient's history, clinical features, and clinical manifestations. TRAP. The diagnosis requires the presence of TRAP symptoms with asymmetrical onset and a positive response to anti-Parkinsonian medications. CT and MRI can be completed to rule out differential diagnoses. Treatment. PD treatment focuses on slowing progression, decreasing symptoms, and increasing quality of life. Pharmacological treatment. Medication symptoms, relieved adverse effects, precautions. Levodopa, dopaminergic. bradykinesia, tremor, rigidity, nausea, dyskinesia, hypotension, dysrhythmias, agitation, hallucinations, confusion. Avoidance of multivitamin pills and diets high in vitamin B6 reverses the effect of levodopa. Contraindicated in narrow-angle glaucoma, levodopa, carbidopa, dopaminergic. Same as above, less nausea, but greater chance of dyskinesia, confusion, and hallucinations. Periodic check of BUN, AST, WBCS, HCT required. Contraindicated in melanoma, narrow-angle glaucoma, bromocriptine mesylate, dopaminergic, same as above, orthostatic hypotension, nausea, vomiting, toxic psychosis, lymphedema, phlebitis, dizziness, headache, and insomnia. Pramipexole, dopaminergic, same as above, orthostatic hypotension, dizziness, lightheadedness, fainting, hallucinations, involuntary, posture changes, rhabdomyolysis, changes in thought behavior. Ropinirole, dopaminergic, same as above, difficulty moving or walking, mood changes, confusion, hallucinations, muscle cramps, spasms, unusual strong urges, swelling of ankles. Amantadine, dopaminergic, rigidity, akinesia, nervousness, insomnia, confusion, hallucinations, dry mouth, nausea, edema, orthostatic hypotension. Benztropine, proseclidine, trihexyphenidyl. Anticholinergic, tremor, dry mouth, blurred vision, constipation, delirium, agitation, hallucinations. Several interactions with medications that have similar actions: diphenhydramine, orphanedrine. Antihistamines, tremor, rigidity, sedation. Same precautions as anticholinergic medications. Selegiline, monoamine oxidase inhibitor, bradykinesia, rigidity, tremor, similar to dopaminergic medications. Entacapone, catecholomethyltransferase inhibitor, by blocking COMT slows down the breakdown of levodopa to prolong its action, similar to dopaminergic medications. Works only when used in combination with levodopa carbidopa. Genome and surgical therapy. Genome therapy is experimental with minimal evidence to support its use. It involves the injection of genes into a patient's cells to replace dysfunctional genes. Surgical therapy is aimed at decreasing the PD symptoms for those who don't respond to medication. There are 3 different categories: ablation, stereotactic ablation of areas within the thalamus, globus pallidus, and subthalamic nucleus. Deep brain stimulation, DBS, placing an electrode to deliver a current into the thalamus, globus pallidus, or subthalamic nucleus to control symptoms. Can be adjusted or removed. Transplantation of fetal neural tissues into the basal ganglia to increase the number of dopamine agonist-producing cells in the brain. Nutritional therapy. Nutritional therapy is extremely important. Malnutrition and constipation can result from poor nutrition. Individuals with dysphagia and bradykinesia require appetizing foods that are easy to chew and swallow, and their diet must include adequate fiber and fruit to decrease constipation. It is recommended that several small meals a day is of more benefit than 3 large meals, with enough time being allotted for the individual to finish their meal and not get frustrated. Meal consistency needs to be catered to the individual's swallowing capabilities, such as cut into small pieces, minced, pureed, etc. Limit protein intake to evening meals to avoid interactions with levodopa due to vitamin B6 content. Nursing assessment. Similar to MS, assessment is extremely important when working with a patient with PD. It is important to ensure that you are assessing for trap symptoms and obtaining pertinent subjective and objective information. Subjective objective. Systems assessment. Past medical history, including CNS trauma, cerebrovascular disorders, exposure to metals or carbon monoxide, encephalitis, positive family history. Excessive salivation, dysphagia, and weight loss general, appearance, affect, speech, blinking frequency. Medications including use of tranquilizers, especially Haldol and phenothiazines, methyldopa, and amphetamines. Constipation, incontinence, and excessive sweating. Integumentary, seborrhea, dandruff, ankle edema. Fatigue, sleep disturbance, difficulty initiating movements, frequent falls, loss of dexterity, cardiovascular, postural hypotension. Diffuse headache, pain in shoulders, neck, back, legs, and hips, muscle soreness and cramping, difficulty concentrating, gastrointestinal, drooling, depression, mood swings, hallucinations, neurological, tremor at rest, location of tremors, Tremor gets worse with anxiety, but not present during sleeping, poor coordination, signs of dementia, impaired postural reflexes, musculoskeletal cogwheel rigidity, dysarthria, bradykinesia, contractures, stooped posture, shuffling gait, possible priority concerns, problems, falls and risk for injury, aspiration and swallowing difficulties, mobility concerns, nutritional deficits, constipation, muscle atrophy and contractures, nursing goals, experience improved symptoms, maximize neurological function, maintain adequate independence with ADLs for as long as possible, optimize psychosocial well-being, nursing interventions. Interventions provided are going to be dependent on the symptoms that the individual is experiencing. Health teaching will be of paramount importance to assist individuals with maintaining good health, encouraging independence, and avoiding complications. Education also needs to be provided regarding adhering to medication regimes and possible side effects, potential manifestations that can be experienced as the disease progresses, the importance of a balanced diet and exercise regimen, and when to seek medical assistance, suspected infection, adverse drug reaction. Based on the symptoms experienced, take time to consider multidisciplinary team members that the individual should be referred to, such as a speech-language pathologist, physiotherapist, occupational therapist, massage therapist, dietitian, social worker, psychiatrist, and pharmacist. It is also important to address and consider caregiver burnout. After providing interventions, the outcomes must be evaluated to determine their effectiveness. If the outcome does not improve, consider alternate interventions and approaches.